And good afternoon, everyone, from St. Louis, Missouri, and the home of the Missouri Institute of Mental Health. My name's Tom Pansella with MIMH. Thanks for taking the time to join us. I'll introduce your speaker to you in just a moment. For those of you who are joining us for the first time, welcome, and for those who have joined us before, welcome back. Just a couple of quick notes. You've seen the screen underneath the video window. You'll see our open captioning. We welcome our caption writer and hope that provides a level of accessibility to this program for you. Below that, you'll see several links that Dr. Muser's provided for us, and he'll mention those during the course of his presentation, and those will be available to you also in a follow-up email after today's program. Along with that PDF file of the slides, you can pop that up in a separate window if you'd like to see those separately, but we'll be switching back and forth to them along the way as well. Along to the right there, you'll see the chat window. That's for your asking any questions or providing us with any other comments during the presentation. We'll hold your questions to the end and ask them on your behalf, but you can certainly put those questions in that box at any time during the presentation. Here's a link to purchase CEUs, still only $10 a person, and we'll keep that link open for a little while and also send that in the follow-up, as well as links at the bottom to the Spring Training Institute. So, I'd like to introduce Dr. Tom Muser, and he is a clinical geropsychologist, and he directs the gerontology graduate program at the University of Missouri St. Louis. Today's program is part of the UMSL Jubilee Web Conference Series, and so we welcome him. He's an associate professor with appointments in gerontology, social work, and psychology. Narrative gerontology is one of his passions, and he also coordinates the UMSL Life Review Project, which pairs graduate students with seniors from the community to video record their life stories. He's a fellow of the Gerontological Society of America and a longtime volunteer of the Alzheimer's Association, the St. Louis chapter. I promised I wouldn't read his whole bio, and I'm going to turn it over to you, Tom. Thanks.
Great. Thanks a lot, Tom. Well, it's a pleasure to be here with all of you this afternoon, or I suppose if you're in a different time zone like out west, it's still morning for you. As Tom mentioned, I'm a psychologist and really have specialized in working with older adults from the very beginning of my career. And we're going to hear a little bit today about work I've done over the past decade or so, certainly not on my own. I have many collaborators, and I'll mention them along the way. I find that research that is related to real-life issues is what makes me get fired up. Research for research's sake doesn't really excite me. I want to do something that has a direct application to people, that makes a difference in people's lives. And so the work today we'll talk about has to do with how individuals think about and react to age-related change specific to mobility. So if we think about mobility is a broad term, and if we think about it in its most broad sense, it's really the ability to get oneself from point A to point B. So mobility may include ambulation, for walking from one floor of a building to another. Along the way, you may have to tackle a staircase. Maybe you need to take the elevator because the staircase is difficult. It may be driving across town. It may be driving across your state, as I actually did yesterday. So driving mobility is the primary topic of today, but you're going to hear me use the word mobility, and I think a lot of the concepts that we'll talk about today are applicable across the mobility spectrum. Anytime, because of changes in health or function or advancing age, that you must change your mobility way of getting around, didn't say that very well, you're going to go through a period of transition. And what you bring to the table, your attitudes, your beliefs, they're going to make a difference in how you adjust. And that's kind of the background for today's presentation. So it's titled Individual Differences in Readiness and Action in Driving Retirement, Making a Successful Transition. I'd like to acknowledge the funding sources for some of this work. The National Center on Senior Transportation was one of the funders, and I've included a link to this organization on the web page, as Tom mentioned earlier. There's also been some funding for this work through the Retirement Research Foundation, so I'm very grateful to the funders of this work. So we're going to talk a bit about contextual aspects of mobility loss. We'll talk about the driving task. We'll talk about general issues more broadly in aging. We'll talk about specific age-related concerns. And then we'll begin to shift into attitudes and psychosocial factors that influence how people manage mobility transitions. I'm a psychologist, so assessment is something that I'm trained to do, I like to do, and I'm going to introduce you today to a tool called the Assessment of Readiness for Mobility Transition, or ARMT for short. So when you hear me use the ARMT acronym, you know that's what it is. I've got a couple of videos that I'll share along the way. The final video is a gentleman by the name of Mr. Thomas, and you're going to see the ARMT in action actually in both of the clips, but I'll show you the longer version with Mr. Thomas. So one of the core issues with mobility change, particularly driving mobility change in aging, has to do with subjective fear. How many of you watching today would readily giving your car keys to a family member, oh yeah, I'm not safe anymore, take my keys, take my car. I know I'm going to struggle. Even though I'm well familiar with the issues, I'm not going to be somebody who's going to give up the car keys easily. I'll probably kick and scream. And I have a feeling that many of you are the same way. And one reason for that is this subjective fear. So you think about yourself as driving successfully. Maybe you're age 80. Well, at age 80, you face an increased crash risk just based upon population statistics. But maybe you're a relatively healthy 80-year-old. So you're driving successfully, you're getting around. And of course, in our country, driving is a way to be engaged. It's a way to do the basics of life, get to the doctor, the grocery store, church, synagogue, temple. But it's also a way that we do the fun things, go to the theater, visit with friends, go out to dinner. It's also how we get around often to volunteer and go to work and do other productive things. So driving is a linkage to other productive activities that matter. And so its loss is something that I think is almost logical to fear in some way. Suddenly you become mobility challenged. Maybe you have a small stroke. Maybe you take a fall and you have strained muscles in your upper back and neck, limiting your range of motion. Maybe you have a change in your vision status such that you've got cataracts or you've got the beginnings of macular degeneration. Any of these and a host of other conditions in aging can impact on your ability to drive. That doesn't mean you have to stop driving. A lot of times it depends on severity of the condition. But now you're mobility challenged. You're on the rocks, so to speak, with my little Volkswagen on the screen. Then you're looking ahead and you're thinking, gee, if I have one other health change, or maybe the doctor said, you know, this macular degeneration you have is going to progress. It looks like it's progressing relatively quickly. You're going to have to consider retirement from driving. So you're looking ahead and you're asking yourself a question. Am I going to fall into a chasm? Is it going to be bad? Or might I be able to continue to be as mobile as I need and want to be after retirement from driving, so making a successful transition? So part of the process of making a successful transition with respect to mobility is, number one, recognizing the impact of subjective fear and working with that. Oftentimes, education about available resources, a person-centered or person-specific approach in counseling where you're really working with that person's feelings and thoughts to try to get them to a point where they're more comfortable with the concept. These are things that we might consider. We might call that mobility transition counseling. And one of the resources that I've provided in terms of the web links and later in the slide presentation is a website that I, along with a number of other of my collaborators, including a social work faculty member at St. Louis University, Dr. Marla Berg-Weger, and I have put together to model different ways of doing mobility transition work. We think that assessment is a critical part of that. And it's not so much assessment of a person's health and function. Physicians can do that, particularly those who are trained in geriatrics. We're talking about assessment of the person, their needs for transportation, but more importantly, what they believe, what they care about. Because it's those beliefs and what they care about that's going to relate to the subjective fear and help them to overcome it. So I've worked in this field since the late 1990s. I have covered many of the topics on this screen, And my knowledge from these various areas certainly has influenced the present work. Some of the work that is related to today's presentation has to do with education. I've done a lot of education of physicians and other health professionals about how do you recognize driving-related issues, and then how do you address them with an older client or patient. So on the right-hand side of the screen, you'll see a paper reflecting work with the American Medical Association. I'm particularly proud of this work, and the AMA has really been a national leader in encouraging particularly physicians, but other health professionals as well, to think about fitness to drive as a standard aspect of primary care with older adults. The reality is, if you live long enough, certainly if you live past age 70, your chances of having to retire from driving because of changes in personal health and function are high. If you live to age 80, it's almost guaranteed that you're going to have to give up the keys at some point soon. So how do we manage that? We certainly don't want to simply have a blanket policy, because people age at different trajectories. You can have an 80-year-old who is aging like a 60-year-old, and vice versa. So it takes an individualized approach, and this is also, I think, where my focus on assessing the person and their attitudes and beliefs comes in. I've also done a lot of work with the state of Missouri, with the Missouri Department of Transportation, with the Driver's License Bureau in our state capital, also with the Missouri State Highway Patrol. The papers that are on the screen now reflect work that I did leading a team of colleagues and students and others to evaluate Missouri's law for at-risk drivers. So in Missouri, there's actually a law that allows family members, law enforcement, health professionals, and a number of other categories of people to report a driver they're worried about. So most of the reports are for older drivers, although the law is non-specific to age. And most states have mechanisms like this. And what happens in Missouri is that you have to then see your physician and get a specific approach, assessment approach done to determine if you're medically fit to drive or not. You may have to go for an on-road test. You may have to have your vision tested. But this is Missouri's way of ensuring that persons who are licensed are in fact safe to drive. And the good news is we found that the Missouri system works actually quite well. We did find some areas for improvement, and I'll share a little bit of that work in a moment. So what do we know? We know that vision, cognition, attention, motor function, range of motion, among other things, do impact on driving and non-driving mobility. The ability to think clearly, to see, to pay attention, these are essential tasks for driving and safe driving, but they also relate to ambulation without being behind the wheel. If you're having trouble with vision, you may well need assistance even just walking around your home or neighborhood. One can be non-ambulatory. You can be quite impaired in terms of your ability to get around on your feet. Maybe you're even wheelchair dependent, yet be a safe driver. So these are not necessarily the same thing. It's possible to be a very safe driver and yet be impaired in other areas. There are driver rehab specialists that actually work with older adults and younger adults to help them drive safely using a host of adaptive devices. While most older adults are safe, and I want to emphasize this presentation is not about get grandma off the road. This is really a presentation about whom are the people we need to be concerned about and how do we work with them in a humanistic, understanding, and yet often firm way to effect a proper transition. Roughly 10 to 15% of older adults today might be considered unsafe behind the wheel due to changes in their health or function, and we'll talk a bit more about that. Timing is a toughie in this because there is no gold standard for identifying and assessing whether someone is fit to drive or not. It really comes down to sometimes good clinical judgment. There's a bit of an art to this kind of work. Also, timing is important. Usually when an older adult is beginning to have trouble behind the wheel, they do what they can to cover it, to make it less apparent. Oh, I missed I hit the mailbox the other day because there was this kid on his bicycle coming up and I really didn't want to hit him, so I wasn't paying attention to the mailbox. So coming up with alternative explanations, for example. So by the time a family member realizes that an older loved one is impaired behind the wheel, usually there is a history. And it's really when in that process that we intervene that really gets to matter. There are persons on the road today that probably should have been off the road a year ago, and yet there wasn't the will or the recognition among those that support them, whether it be family or professionals, to actually make that change happen. The good news is that most older adults will self-regulate. This was true for my own grandmother. She had macular degeneration that was worsening. She knew when she was having trouble seeing out of her periphery in the grocery store parking lot and almost hit someone. For her, that was enough to say, I'm done. The big problem often with safety in older drivers is the impact of dementia, particularly Alzheimer's disease. By definitions, persons with Alzheimer's disease are losing memory, but they're also losing the ability to step back and be self-observant. So it's awareness of deficit. And those who don't have good awareness of deficit are often our biggest problem and are the ones that often will drive too long. So the driving task involves multiple elements. The operational aspects are what we learn from the get-go. How to turn the wheel, how to apply one's foot to the brake, how to master the clutch, how to turn on the windshield wipers or the turn signal. But there's also the tactical. Where do I need to position my car to effectively make this left-hand turn, staying in my lane and avoiding oncoming traffic? And then there's the strategic level. Planning a route, thinking about where you are relative to the roads you have to be on maybe 2 or 3 turns from now. All of these aspects need to be working correctly to be a safe driver. And changes, particularly in vision, cognition, and sensory motor functions, reaction time being one, are things we worry about in some individuals. Remember, there can be ways to compensate. And so again, don't take anything that I'm saying as absolute. It's interesting in Alzheimer's dementia, for example, the operational aspects of driving are the last to fail. So a person can have moderate, pretty advanced Alzheimer's disease, have very poor memory for recent events and spotty memory for long past events, and yet still be a very effective operational driver. The reason is the driving task is overlearned. We learn it young, and it's part of our procedural memory, and it's retained. Sometimes a person with Alzheimer's can't describe how to drive a car, but you put them behind the wheel, they'll do fine. On the mechanics side, it's the higher order tactical and strategic that fail first. So the biggest warning sign for an older adult who has early Alzheimer's is getting lost. They have trouble with wayfinding. They can't map their route in their mind anymore, and they may drive too long. They could even drive 100 miles before realizing it. That's a big red flag of an issue that needs to be looked at. So here on the screen, I've got a little animated GIF. We put the older adult in the yellow Maserati for fun, and the other drivers are in these old red beaters. And you'll notice that the older driver waits for the first car, but then misjudges the separation and turns left. And in fact, left-hand turns are the most difficult maneuver for an older driver who's having trouble with cognition, attention, vision, range of motion, some of the other issues I've mentioned. And the reason being that as we age, our ability to judge distance, particularly in low light situations, is not as good. So at night, a left-hand turn can be particularly troublesome for an older adult. So a person who's having trouble finding their way, who's making errors in more complex maneuvers like left-hand turns, is someone we would be concerned about. This has a phrase to it. It's called medical fitness to drive. And early in my career working in this field, I was very focused on this issue, particularly with dementia. Worked with a number of physicians at Washington University in St. Louis, including Dr. David Carr. And David is a good friend and really an excellent researcher and clinician in this area. It is interesting that his last name is Carr. That I don't think that led to his decision to do this work. Some of the work, though, that I'm particularly proud of is impact that I've been able to have on how medical fitness to drive is evaluated in the state of Missouri. The paper that's on the screen now was just published this past year, And it details work where we looked at how medical fitness to drive is mandated and required in all 50 U.S. states and some of the provinces of Canada. And we took what we thought were the best practices across these other jurisdictions. We also looked at data that we had from that AAA report that I showed you earlier about evaluation of at-risk drivers in Missouri. And we put together what we think is a very nice form. It's called Form 1528. If you're interested in this form, you can go to the Missouri Department of Revenue website, or you just go to Google and type in Missouri DOR 1528, and you'll turn it up. The form is designed to guide the physician evaluating the older driver through the critical steps of assessing each aspect of medical fitness to drive. And you'll notice on the right-hand side here, each area, for example, the cognitive area, after checking off what's going on, the physician has to give a rating of the extent to which the conditions listed above impact on driver safety. And we found that these interim ratings are very related to how the physician finally rates safety at the end of the form. And this form is used now for all drivers reported as unfit in the state of Missouri, about 90% of whom are over the age of 50. So we're worried about older drivers because of age-related change in health and function. We also worry about older drivers because their capacity to withstand the impact of a crash is less. You're more likely to die if you're in a crash if you're over the age of 65 or 70 because you have less physical reserve. So we're also interested in saving lives of the driver, not just the others on the road, by looking at fitness to drive. Now the graph on the screen is an interesting one. It shows the U-shaped distribution of crash deaths that some of you possibly have seen before. Of course, the teenagers are a particular concern. And I hate to say it, guys, but we're also the worst because the blue line are the guys, the red line are the gals. But both, whether you're a 17-year-old girl or boy, you are at risk, at greater risk in a crash than if you are a male or female at age of 45 or 50. Roughly after age 70, the curve goes up again. It's also worse for men than it is for women. What's interesting, though, is that there is a sociological phenomenon, at least in part, behind the increase in male fatalities. Women in general tend to be less frequently the primary driver, although this is probably changing as our culture changes. But also women tend to be more cautious in general when they do notice changes in health or function that impact on driving. So women are the first to pull back on their driving. Men tend to drive too long. They tend to push the envelope. As again, I said earlier, I probably will be one of those. Maybe you will too. So men, by their style in general, these are group level comparisons, so not all men and women are like this, but we men will often drive too long. We place ourselves at greater risks, we're more likely to die. So it's been suggested that one way we can intervene to support elder mobility is to support women to drive longer while we support men to drive less, and that will actually help safety. I actually believe that that's true. It's just a challenging one. So when we think about mobility in aging, we're not thinking about it as an either or at least we shouldn't. Those who are afraid of it will think of it as an either or, but really it's a continuum. And as we experience functional changes over time, we go through a process of adaptation. For some of us, that adaptation is subtle. We do it without even thinking about it. It's not conscious. There comes a time when that transition from driving to non-driving needs to happen for reasons of personal and public safety. Often when we reach that point, the person who's the target, the older adult having trouble, has really not even recognized they've been in a process of adaptation for a period of time. For them, it seems abrupt. And family members that go in and take the car keys abruptly are not really helping, although maybe they think they are. That even in a dire situation, or what appears dire, maybe there's been a crash, it's still important to take a careful and somewhat go-slow approach. The key question is, how do we facilitate the transition from one reality of mobility to another, from driving to non-driving mobility? We want to promote positive mobility, whether it's behind the wheel or whether it's non-driving. So a person still needs the freedom to travel to where they want to go. Many of our public service forms of transportation, particularly government-sponsored, focus on the essentials, like getting to the doctor or the grocery store. And yet, for a good quality of life, you need to go to the theater sometimes. You need to go to church. You need to do other things. You need to be independent and have choices. In cities, this is a lot easier than in rural areas. We need roadways and systems designed for the needs of older adults, and this is actually happening. If you've been a driver for more than 20 years, you've probably noticed that street signs, the text on street signs, but also the reflective quality of street signs has gotten bigger. Well, that's partly to make our roads more accessible to older drivers. Older adults need knowledge. They need to know what the resources are, and they often need support to access those resources. So I'm part of something called the Subcommittee on Elder Mobility and Safety, which is part of what's called the Missouri Coalition for Roadway Safety. SaveMoLives.org is the website. And this is our definition. So we are working statewide to look at how we can enhance elder mobility in St. Louis, in Columbia, in Kansas City, but also in Cape Girardeau, in Kirksville, in Joplin, in smaller parts of our state. It's a challenge. Resources are tight. But it's interesting when you begin to look at local areas, many grassroots mobility solutions exist. These are locally developed and they work. And we need to actually support these more. Before I go further, I want to make mention of one excellent resource for families, but also a really good resource for professionals. This is the We Need to Talk booklet. It's published by the Hartford Insurance Corporation. It includes a number of helpful worksheets, but also guides for how to work with older adults and their families. It's available free of charge from the Hartford website, and you can even order it in bulk as a patient or client handout. I strongly recommend you look at it. So mobility transitions are normative. We tend to forget this in the moment. Personal mobility involves moving from place to place at will. How you get there will depend on lots of factors. But there comes a time at different stages of life when we have to transition. Some of these transitions are built into the lifespan. So the first red line on this graph really relates to what my 16-year-old son is going through right now. He's learning to drive. He's been dependent for his mobility on me and his mom, and now he's venturing into this new realm of driving mobility. He still could rely on public transportation, and many teenagers and adults do that. But driving your own vehicle in the United States is the primary means of mobility. There also comes another point in the lifespan when you transition again away from driving. In this graph, it's a dotted line because we have to draw it for every person. We cannot make a general blanket statement because, again, as I said earlier, people age in different trajectories. And that gets difficult because it takes time, it takes intention to figure it out. But even after one makes that transition, one still can get around. There is a transportation service available in many communities of the United States called Independent Transportation Network of America, or ITN. ITN is a grassroots volunteer driver system where you buy an annual membership and you also pay a per ride fee. And oftentimes the drivers are other retired adults who are healthy enough to still be driving. And they can drive you to the grocery store as much to the theater. And this grassroots solution is one of the solutions I think that is going to help with the non-driving transition for many older adults in the future. For my own research, there's one paper that I look to particularly as influential for work I've done recently, and it's a paper by Ann Dickerson and colleagues that was published in the Gerontologist in 2007. Ann is an occupational therapist. Occupational therapists are very involved in older adult driving issues. The American Association of Occupational Therapy is actually a national leading organization I didn't include their website in the links for today, but certainly take a look at their older driver page. And in this 2007 paper talks about the state of affairs of older driver research. A lot has happened on the infrastructure side. So I mentioned signage before. Rumble strips are another way that our road engineering help us to stay safe. A lot's happened actually on the medical fitness side of the equation. How do we determine if someone is fit to drive or not because of changes in health or function? What's missing is the bridge between what's happened either on the engineering side or the alternate transportation side and the medical. And that's really what I'm looking at. I'm interested in understanding how people make the transition, how they think about it, how their thoughts and attitudes influence what they do. And this is really the gap that this paper says exists, and I and my colleague Marla in particular have been trying to tackle it. There's an interesting report, an annual survey that was funded in part by the MetLife Foundation, published by the National Association of Area Agencies on Aging. It surveyed all area agencies on aging nationwide in 2010. This survey is looking at the status of all types of services for seniors. For the first time, this survey included questions about something called mobility management. This is a growth edge in terms of our services to older adults. It's a new professional designation that can be housed in different settings, and different professionals can participate. So a social worker, for example, or an occupational therapist, even a psychologist, could be a mobility manager. But it's someone who helps the older adult navigate the transition. Very few local areas have this service right now. And you can see the circled box, possibly if your resolution is high enough. 25% of the providers surveyed had something along these lines. A staff person or more whose at least part of their designation is to help older adults navigate this mobility transition. I'll tell you, the aging tsunami is coming. We are aging fast. The baby boomers are aging very rapidly. We're going to need more professionals in this area in the future. One of the red flags for when a mobility transition is going to happen is physical frailty. I would call it a signal for mobility-related assessment, counseling, and planning. There's sort of a frailty phenotype that has been found. Persons who have falls, who have increasing numbers of hospitalizations, who are physically frail, maybe hunched over, they have less muscle mass. Roughly 7% of community-dwelling elders we would consider frail under these definitions. So if you're working with an older adult, maybe you're meeting and assessing them for the first time, and you notice that they walk slowly, that they are weak, that they have some of these signs of frailty, this is a trigger for mobility-related discussion, assessment, and planning. There's a paper by Howard Phillott and Robert Butler that I really like. It was published in 2009. Robert Butler was a famed gerontologist who died a couple of years ago. And they talk about something called the frailty identity crisis. And they're talking not just about mobility change, but how the experience of frailty really challenges your sense of self and identity. And honestly, I see this as a great area for intervention for mental health professionals especially. There are existential issues involved in this, but there are practical functional issues as well. And here's just a little statement. They're saying such research may validate the concept of the frailty identity crisis and might assist clinicians in helping patients to better recognize and understand the implications of frailty as a transitional stage in life and achieve an adaptive rather than maladaptive psychological response to frailty. Learning how to navigate and remain mobile, even if not driving, I think is one aspect of that transitional stage. Now, Phillott and Butler were saying, we don't have enough research about this, we need to do more, but they put it on the table. And I encourage those watching, particularly who are mental health professionals, to take a look at this paper. It's very good. Individual perception matters. I don't probably have to tell this audience that. You probably know it very well. Attitudes can influence how we choose to cope with life's ups and downs. And we may recognize something in an objective way, but then subjectively choose to view it another way. And yet it's often the subjective way of viewing it that really matters in terms of behavior. So here's an example. Here's Andrew. He's 82. Subjectively, he says, yeah, I can hardly walk down my driveway to get the paper in the morning, yet I can still drive successfully to get to my bridge club, to church, to visit with my grandkids 30 miles away. So what? I can't climb stairs without help any longer. Big deal. I'm still getting around for what matters to me, and that's what's important. So that's his subjective view. That's his passion about his ability to drive. Well, let's look at him objectively. He's overweight. He's diabetic. He has mild peripheral neuropathy, so loss of sensation in his extremities. He's moderately deconditioned due to insufficient exercise. In fact, he's at risk for frailty. He's on multiple medications, which is a common issue for older adults. He's a moderate fall risk because of this collection of problems. He's still mentally alert. He's got good eyesight, good neck range of motion. He's got a safe driving record to date. So maybe Andrew, for the next year or two, will be a safe driver. These conditions, objectively, though, give me pause because I think, these are going to get worse in all likelihood as he ages. There's going to come a point when he's going to need to make this driving to non-driving transition. Should I bring it up with him now, even though it's not an immediate concern? Maybe talking about it now will plant a seed for later planning and action. Oftentimes, we fail to make that step when we're intervening with older adults and their families. Oftentimes, there are more pressing needs, and we forget or we choose not to make the prediction. You know, about a year from now, you may have to give up the car keys. It's not news that anyone wants to hear or anyone wants to give, but it is actually realistic news to give. And the reality is that once you work through the fear, there are options. So people respond differently. So here's John. He hit a parked car 2 weeks ago. He's 81, widower, 8th grade education, retired carpenter. He's active in his church. He bowls. He also delivers Meals on Wheels for his area agency on aging. I love being active and giving back to my community, he says. My car is my independence, and at this stage of my life, I can't stand sitting home alone. I'm at my best when I can get out and do something productive. Okay? So he hit a parked car, but he's also probably not someone who's going to necessarily frame that in a way, maybe that's evidence that I need to do something different. So here is Mary. She hit the same parked car, same event. She's 74, married, caregiver, college degree, retired secretary. Husband has Alzheimer's. She's a caregiver. He, referring to the husband, used to do all of the driving, and now I have to. I question how long I can and really want to do this. I have an appointment next week to look at an apartment at a local assisted living facility. Same circumstance, very different response depending upon who the person is. For John, he might consider this an aberration. It certainly doesn't fit with his conception of himself. He's probably not going to make any big changes in driving. For Mary, it's one more piece of evidence that she needs to do something different. And oftentimes moving to a place where you don't have to provide as much transportation for yourself or it's available to you there can be helpful. So a model that Marla, my colleague, and I have found particularly helpful is something called the trans-theoretical model developed by Prochaska and colleagues. And this was developed specifically with addictions in mind and how people may be addicted to smoking or drinking or whatever it is, go through the experience of recognizing that there's a problem and actually changing their behavior. I don't have time to go into this, but if we look at John and Mary, the two people that have hit the parked car, they're in very different points. Mary has already been actively thinking about driving and its impact and where she wants to be. So hitting the parked car was a wake-up call for her. It was one more piece of evidence that's moving her into the action phase of making a change. In her case, moving. John is what we might call a pre-contemplator. I'm doing great. He's got this piece of evidence that maybe he's not, but he's probably not ready to deal with it either. And so I mentioned before a person-centered approach. We need to meet people where they are along this continuum. I want to share with you briefly a clip of someone I would call an active planner, someone a lot more like Mary. She is responding to items administered through our ARMT scale that I mentioned earlier. And you'll see Marla, my collaborator, on the screen. We're modeling in this clip not only how to administer the scale, but how to use the scale as a way of broaching the topic and engaging in dialogue. And you'll hear that the woman on screen, a woman by the name of Faye, is very active in talking about the implications of this. We'll watch just for a couple minutes.
Asking others for help with mobility means that I am losing my independence.
No, I don't. I think the idea of independence will change if you have to ask
Okay.
for help. It changes.
So,
But doesn't mean you're giving up all of your independence.
okay. So on that scale of 1 to 5, the statement again is asking others for help with mobility means that I am losing my independence. Sounds like you...
I disagree. I think about a 2.
Okay.
Because they're all areas of independence. It's not just driving.
So you would, in a situation of having mobility change and loss, you would redefine your definition of independence?
Oh, yeah, I think so.
Okay. So you could still see yourself as independent even if you didn't drive?
Yes, because you have other things you can do, other decisions to make, other choices.
Faye here is the ideal client because she is thinking flexibly. And I'll tell you that when we administered our ARMT scale to her, she scored in the low range, which means she actually has high readiness. She has a flexible view about aging. She understands that things change and that independence is a relative term and that that's okay for her. Some other work that I've done more recently will be the final portion of the presentation. Because I'm not used to speaking to a camera with no audience, I prepared more slides than now I have time for. So perhaps some of you in the audience can empathize with me. So I'm going to move quickly and skip a few things. But I'm speaking from the work represented in the 2 papers on the screen. One called Decoding the Miss Daisy Syndrome. If any of you have not watched Driving Miss Daisy recently, pull it out. It is a wonderful explication of the experience of the transition from driving to non-driving mobility. Just dynamite. It's also pretty funny. And then the paper on the right is the paper that details our assessment of readiness for mobility transition. Now, I've given you a link to be able to download this tool. Perhaps some of you have done so already. So we went through a project that had multiple phases. We started with focus groups, and we went into talking with older adults, community-dwelling elders of different levels of function and disability. We wanted to know their views about retirement from driving, but more specifically, how do you prepare and what relates to being prepared? We then developed an item set where we administered this to a large sample. I'll tell you briefly about that, to develop this tool, the ARMT. We did a secondary validation. And in fact, now we're doing, in step 4, a community application of the ARMT where we're doing data collection over a period of time. And we're looking at the predictive validity of the scores on the scale. Does a high score on the ARMT predict that a person will struggle in a mobility transition? We think so. Our preliminary data is saying yes, but stay tuned. I'll have to come back and do this next year. So these are the first 2 samples. The focus groups were 30 older adults. Then our development sample was 297 older adults. These are community-dwelling volunteers. Here's a picture of one of the extended large focus groups. We did 3 small and 1 large. And we took the seniors that participated were happy to have their photos taken. And we were looking at different concepts. One of the concepts that came out of the focus group is this notion of anticipatory anxiety. I used the term subjective fear before. It's the same thing. I'm worried. I don't know what's going to happen. And some of you may know that there's research showing that anxiety can be activating to a certain point. It can be then debilitating in terms of coping and adaptation. And so here's a quote from this individual. I'm wondering what's going to happen when I no longer can drive, because I mean, not too long ago, my car had to be in the shop overnight. I mean, I wasn't even planning on going any place that evening, but it was like I don't have my car, and it's such a feeling, such a strange feeling. It's not helplessness, but it's almost helplessness. Another concept that we looked at, and it makes sense, we might call perceived burden. If I have to give up my car keys, I'm going to have to rely on my adult children or my spouse or other people more, and I'm not so sure I want to do that. And if you're a fiercely independent person, that's going to be a particularly difficult thing for you to manage. Another is avoidance. Some people just, it's not a big deal. I'm not going there. It's not going to happen to me. Or even if it is happening, I'm not going to worry too much about it. Okay. Finally, another concept we called adverse situation, and you'll see that these concepts are all in the scale. We found in some of the people we interviewed and also surveyed this fairly global negative viewpoint about age-related change in general and handing the car keys in particular. And you think about, you have this very black hole way of thinking about it. Oh, it's just terrible. That's going to raise subjective fear significantly. So we felt it important to measure those beliefs as well. So what do community-dwelling older adults believe about mobility and aging? Just a few slides to show you, and this is from the 297 case sample. Our participants generally disagreed strongly with the following statements. The middle one, I feel worthless when I have difficulty getting around. It's a shameful thing for older people to have to rely on others to get around. I was glad to see strong disagreement with these statements because these are the type of beliefs that would not be helpful with a person undergoing a mobility change. Here's a few more. You've got to print out of my slides, so I'm going to skip through this. Generally, our participants strongly agreed with things we'd like to hear. I would be willing to use alternative transportation. I'm at peace about my health and the mobility I still enjoy each day. So in general, many of the people that we surveyed were reasonably ready or very ready in terms of their attitudes to deal with a mobility change. But when you begin to look at individual people, it's a different story. I'm going to skip this slide. And this one too. So we developed this scale. It is psychometrically valid, very good internal consistency, reliability. We are determining now the reliability over time, and we're also looking at the predictive validity. So stay tuned for more research. This is what the scale looks like. You'll see that it is a 24-item scale. It's an agree-disagree scale where 5 is strongly agree. And the subscales are scored out to the right. Because we have different numbers of items in different subscales, we use mean scoring, which means you have to have a calculator to come up with the final score. There is a website, and this website is provided to you. And this website is our effort, Marla and mine in particular, to provide the kind of backup that you in the community working with older adults will need to be able to effectively use the scale, but also integrate it into a mobility counseling intervention. It's based on the notion that coping is not a single event. When a life event occurs, there are many aspects to it. So this is an image I took from Medscape for full disclosure. Whenever an event occurs in a person's life, let's say it's a crash. You just experienced a car crash. You're the driver and you're the cause. How you're going to cope in that moment is in part based upon who you are and what you bring to the table. Your knowledge, your beliefs, your attitudes, how you've coped in the past. It's going to relate also to how you understand the events, both in the immediate sense, the primary appraisal, but also how you understand yourself in those events over time, the secondary appraisal. Readiness, as measured by the ARMT scale, is reflective of the antecedents. It's not what you're doing in the moment to cope, but it's the background that influences present behavior. And so we're hopeful that the ARMT scale is successful at quantifying readiness factors that matter in terms of mobility change. So far, we've worked with many professionals in the community who have told us in their belief that it is. The scale has been adopted by researchers in Canada. It's also been adopted by a national healthcare organization that's going to use it in clinics in 47 U.S. states. This is another way of showing the same image that I showed you before, but maybe a little more cartoonish, that we bring person-specific factors to the table. Here's the crash, and then we work it through. And how we work it through will be influenced by our readiness level. So the ARMT is a measure of attitudinal and emotional readiness. High scores will tend to be more anxious and threatened by mobility change. They may also be more anxious and threatened by other age-related change. They fear the prospect, they worry about it, particularly becoming dependent on others. They prefer to avoid it if they can, and they often have a global bad viewpoint. Okay? So from a therapy or a counseling intervention perspective, these are all areas that can work as levers. If you assess these contributors to a way a person thinks, you can then work with it. One way that we looked at our data from this is to take the high scores, the people scoring 1 standard deviation above the mean, and the low scores, those 1 standard deviation below the mean. So the tails of the distribution, and we graphed those two tails. So the low scores are in blue on the screen, and these are the people we would generally consider by their total score to the ARMT scale as generally ready to manage a mobility transition. They've got attitudes that are flexible, they don't have this global bad view, they're willing to rely on others. The green people are those that score high. Now this is not a unitary construct. It's possible for someone who we would consider at risk to still demonstrate pro-coping, positive aging viewpoints. It's really the collection of attitudes that matters. So in this item, I never thought about mobility change until filling out this questionnaire. You'll notice how the distribution breaks out. Many more of the high scores, the people we would consider at risk, have just not thought about it. And thinking about it is the first step. Here's another one. Older people are pushed to the side because they can't keep up. So think about that attitude and how that might play out in terms of how a person manages in the community. If you're worried that you're going to get pushed to the side, you're going to sort of stick to your guns even when you're having trouble. And you'll see the same breakout. The low scores, the people we consider very ready on our scale, they're saying, I don't buy that at all. The high scores are saying, I buy that. That's me. That's how I think. And there's a few more. I'm not going to go through these. You can look at these on your handout. So the ARMT scale is a way to consider readiness before intervention and to begin to categorize people and think about how you might intervene differently. So I'm going to start at the bottom. The green light, the low score. This is the high readiness person. This is the woman Faye you saw in the video a moment ago. She's not going to need a lot of emotional hand-holding, for want of a better phrase. She's going to be able to flexibly talk about the realities of age-related change and collaboratively work with you to figure out alternatives. She's going to be actively engaged, and she's not going to be overly fearful. On the other end, we've got the red light. This is the high score, the person we would consider low readiness, the person that has pretty much strong agreement with many of the statements in the scale. These are people that you're not just going to go right into and say, you know, I think next month we need to have you stop driving. That's a prescription for a failed intervention. This is someone you have to work with and gradually help them to work through their fears, to understand the issues, to begin to learn that relying on others is not a bad thing and it's possible in their family and their community. The yellow light people, they're sort of in between. So the ARMT is designed for either paper or spoken administration. On the back side of the scale is enough information for you to understand it and to score it and to interpret it. However, as our papers continue, we will have more about that being published. Our latest interpretive paper is coming out in the Journal of Gerontological Social Work in the next 3 months. So you can do a total score, or you can score any of the 4 elements that I mentioned before, and that's down here. And you'll see that there's the division because of the mean scoring. And then you know if a score is high or low based upon these guidelines to the right. So I'm going to show you just a 2-minute clip of Mr. Thomas here. And I'm going to do it by pulling out of the slides here and pulling up my Windows Media. I just want you to listen to how Mr. Thomas responds. And I'm going to change my plan because it's not coming up. You test this technology ahead of time and then it doesn't work, right? So we're going to do it from here.
24 items here.
You know what? I'm going to describe Mr. Thomas because I don't have time. Even better. So he's a 90-year-old retired engineer. He lives with his wife in a 4-bedroom, 2-bath suburban home. And Marla and I did a home-based intervention with him, starting with assessment. If you want to see this intervention, just go to my website. It's all there. Mr. Thomas does not score high on our scale. He actually scores in the yellow area. He demonstrates some attitudes that we would consider problematic for a mobility transition, some attitudes that we would consider very helpful for a mobility transition. So here are his scores. And you'll see that his total score was well below the cutoff. But he's got a couple scores that are nearing the cutoff. So for perceived burden, he's relatively high. He's ambivalent about relying on others. Remember I said older men tend to drive longer than they need to? He doesn't like relying on his wife, even though he could. He also does almost go over the cut point for that last one, adverse situation. He does have a global bad view about what's going to happen when he can't drive. On the other hand, his avoidance score is almost at the bottom of the scale. He's willing to talk about it, and that's why he was willing to have us spend time with him in his home. It doesn't change the fact that this is a mental struggle. So for persons like Mr. Thomas who are in the yellow range of the scale, it really takes getting to know him and understanding where he's at. And the ARMT scale is one way to begin to quantify. Is it necessary to administer the whole ARMT scale and score it? Yeah, from a research perspective it is, but not for a clinical perspective. You could actually administer just part of the scale. Now on the website we have a short form. It's just 8 items. It has not undergone the rigorous psychometric validation of the full version, so just be forewarned on that. But if you need a short form, it's pretty good, and it correlates well with the total score. But a pattern or a profile on this scale gives you, as the counselor, the psychologist, the therapist, the social worker, the nurse, the information, the occupational therapist, the information that you need to look at this person and understand where they're going to need extra guidance, a softer touch. Mr. Thomas, one of the things we worked with him on is that notion of the global bad. And we were able, just through some back and forth discussion, to help him see, I've got alternatives. And one of the alternatives he and his wife were considering was moving to a retirement community. And in fact, that did happen. And that really solved the problem. And I would imagine if he took this scale again, he would score differently. So I've given you this resource. This is the actual web address, www.umsl.edu/MTCI. I appreciate your attention today, and I'm going to open the floor to questions.
And if there are any questions, please use the chat window next to the video window. We did have one come in, Tom. This is an interesting leap in the technology field here, and we've seen a lot I've seen a lot in senior centers, a lot of video games, a lot of electronic game systems in play.
Right.
And can playing video-based simulation games help older people prolong their ability to drive, especially if they're playing like driving simulation games?
Yeah. That it's a really good question. I would love to say yes. The reality is, though, a static screen simulation where you have stereo audio out of 2 speakers and you're using a mouse is so far removed from the actual experience of driving a car in the real world that developing tools on the computer that truly help you in the field, it's a tall order. And then really, how do you quantify those tools actually really made a difference. Okay, I suppose you could look at crashes, near misses. This type of research is being done. There's a lot of work happening through MIT, through a number of other institutions where they're outfitting vehicles with cameras in all directions, and they're actually looking at, can interventions in an office make a difference on the road? Now, I will tell you there is one product I really do like. It's called RoadWise Review. It's a product of the American Automobile Association, AAA. It's available at your local AAA offices. I think it's $10, and it's a DVD, and it's a self-training and self-assessment tool that seniors can take home and use on their home computer. It's a really nice tool for beginning to think. If you're somebody who's contemplating, I'm not so sure that my driving's the best, this is a nice tool to help you do some quick assessment. There's a built-in assessment approach where you go through various visual and reaction time tests that gives you a printout on where you fall. And the nice thing is, you're the only one who knows the scores. You then make the decision on what to do next. So there are organizations creating technology-based supports to help older adults stay behind the wheel longer. I hope that they're successful. To my knowledge, there is none out there that's really been proven.
All right. Well, I think that brings us to the end of our hour with you this afternoon. I'd like to thank you for your time, folks. I'd like to thank you for your time joining us this afternoon. There's going to be 4 more programs in our UMSL Jubilee web conference series. Stay tuned to the website. Spread our email address around, our website around to your friends and colleagues, because I think this is going to be a good series highlighting the work that's going on at the University of Missouri St. Louis. Also, we've got other programs in our regular web conference series, and our website will also be populated with those as they pop up. There's a lot of them coming up. So I thank you again for your time this afternoon. We'll keep that CEU link open and give you all the rest of those links in our follow-up email along with the evaluation. And Tom Muser, thank you for joining us this afternoon.
Thank you.